Good morning. Good morning. This is Dr. Lowe, and I wanted to talk to you today about anticoagulants and antiplatelets. So, I put together some slides that I've located from a source online, and they're excellent, and I love the graphics. So, I'm going to use those in kind of a slide share that I put together. So, when we think about antiplatelets and anticoagulants, we know that the purpose is to what we call thin the blood or prevent clotting. And similarly to when we talked about medications for blood pressure, we said there are quite a few medications for blood pressure: beta blockers, calcium channel blockers, angiotensin receptor blockers, and they all work for the intense purposes of lowering blood pressure, but they do it in different ways. So that's kind of what I want you to think about with antiplatelets, anticoagulants, is that the purpose is to prevent blood clotting, to allow a pathway for oxygenated blood to get through the blood vessels, but they do it in different ways. So first, let's look at normal hemostasis or normal clotting. And it says that in following an injury to a blood vessel, so our blood normally forms a clot to prevent bleeding out of the blood vessels. That's the purpose of it. So when there is an injury, such as when we have an injury to part of our body and the blood vessel is affected, we usually have vasoconstriction. And so that blood vessel that's injured will constrict or get smaller. And that's a way for it to pull the walls of the blood vessel together to close that injury. And then platelets that are circulating in the blood all the time will stick to that injury and form the first part of what we call a plug or a platelet plug. When that happens, chemical messengers are sent out to continue the rest of the coagulation cascade or other clotting factors that come to the site to form a more permanent clot, but also signaling regeneration or repair of the blood vessel. So that's what normally happens. So we want that to happen. It's beneficial, necessary, so that we don't bleed out of our blood vessels and lose all of our blood that we need. So why would we need to give patients antiplatelets or anticoagulants if our body is normally repairing itself from injury? Well, I want you to think about patients who have narrowed, very small arteries, arteries that may be damaged from things like um, um, atherosclerosis, so very small, hardened, narrow arteries that can happen due to hypertension and high cholesterol. Also, patients that have increased risk of blood clotting in other parts of the body. So, not just in the peripheral arteries, but clotting increased risks in places like the heart. So, patients that have AFib, patients that have mechanical valves. So, the valves that are mechanical, so whether we're talking about the tricuspid or the mitral valve, they don't operate exactly like our normal valves would. And because it's an artificial valve, there's an increased risk of blood sticking to that and forming blood clots. So we may need to make the blood a little bit thinner to prevent that sticking around those mechanical valves. It could also be patients who have a history of things like a heart attack, which happens when very small coronary arteries are blocked by blood. So clotting happens in those. So we want to make blood thinner to go through those very small arteries without clotting or clogging up the valves or clogging up the arteries, excuse me. Patients that have a history of an ischemic stroke. So a stroke that's due to a blood clot in the brain. Again, very, very small arteries that are at an increased risk of having another clot. And then patients who've had a DVT or a deep vein thrombosis, which is a clot that can happen in the lower extremities. And patients who are at risk for this are patients who have had um, problems with, again, their arteries and blood vessels, damage to those, but also patients who are sedentary, who are not up and moving and using their extremities for ambulation, such as a patient who may be bedbound or a patient who has had surgery and is in the bed for a prolonged period of time, someone who's not as mobile as they were before, so post-surgery or things like that. We don't want to increase that risk of blood pooling in the lower extremities by them being sedentary. So they may be on a blood thinning medication. So a number of reasons why. So then if we look at this coagulation cascade, the important thing from this is saying that there are different pathways that a clot happens. Similarly to what we talked about, cardiac medications, there are different ways we can affect the heart, the beating of the heart, the amount of fluid that goes through the heart, all for the end result of lowering blood pressure. This is similar. There are different pathways or ways that a clot is made, and different types of medications affect different parts of this cascade or pathway to prevent the end result of a clot. Now, we're not preventing a clot, preventing blood from clotting, period. Again, we need blood to clot, but it is slowing the time for blood to clot. And in turn, it is making the blood less likely to form a clot. So let's look at these two different pathways. They're circled here, two different ways that the clot happens. One's called an extrinsic pathway, and it says figure 7 is activated, and so it's a tissue factor. That's released, that's those chemical messengers released by an injured vessel. And so that reaction happens very quickly. And we want that to happen. If a blood vessel is injured and that factor 7 is activated by that chemical messenger, we want a blood clot to happen very quickly so we don't lose a lot of blood out of that vessel. An intrinsic pathway is factor 7 is activated by another method. It's exposure to collagen from that vessel wall. Or a blood cell membrane. And so this is where the blood vessel is actually signaling for repair of that blood vessel. And in turn, blood clotting is activated too. I think the reason that the body does this is because if there is one of these pathways that is interfered with, or one of these pathways that's not working properly, it's the body's way of kind of preserving itself and saying that we have more than one way for a clot to happen so that we don't bleed out or we don't die, okay? So different medications affects different pathways at the end result of slowing down the clotting mechanism and preventing blood clots from blocking up those damaged arteries or from clotting around artificial valves or preventing blood clotting from happening from AFib. Now let's back up and talk about AFib for a minute. So AFib is the atrium, the top chambers of the heart. And if they aren't getting a good squeeze, a good contraction, what can happen is that blood stays in those atrium longer before they go down into the ventricles. And anytime blood sits still for a period of time, it has a risk of sitting there and clotting or sticking together. So if we make the blood a little bit thinner, or we prevent this clotting from happening for a longer period of time, we're less likely for those clots to happen before they can move from the atrium to the ventricle. So we can see there's two different pathways that may be interfered with. And so different medications affect different parts of the cascade, okay? So let's talk about the difference in anticoagulants and antiplatelets. We know that the bottom line is that we are going to prolong the time it takes for blood to clot or blood to get thicker in an area. Anticoagulants inhibit the production of clotting factors. So we looked back here, we saw the clotting cascade. Anticoagulants are going to affect something on that clotting cascade so that it takes longer for blood to clot. We have a less risk of blood clotting and producing a blockage in an artery. Antiplatelets affect platelets. They are different than the clotting cascade. Platelets are always circulating in the bloodstream. So we don't have to call out and say, I need a chemical messenger to release clotting factor. Platelets are right in the blood vessels. They are the first things to come in contact with the blood vessel if it's broken. So antiplatelets interfere with the platelet aggregation. They interfere with the ability of platelets to stick together to form that initial clot. So in turn, it decreases the risk of blood sticking together and clotting in the vessel, okay? They're used for different reasons, and we'll talk about that as well. Let's look at anticoagulants. When we think about anticoagulants, I want you to think about three major categories. One is Coumadin or warfarin. One is heparin or Lovenox, which is a derivative of heparin. And one are the new 10A inhibitors. Again, anticoagulants, all affecting some part of the clotting cascade. They all affect different parts of the clotting cascade. They all have benefits and risks or things that are problematic about them. So we'll talk about that. Warfarin or Coumadin is really the oldest type of blood thinner or anticoagulant. I'll refer to as anticoagulant. So warfarin or Coumadin it antagonizes, which means that it blocks the production of vitamin K. Vitamin K is produced in the liver. Okay, we have to have a good functioning liver to make vitamin K. And we have to have a diet that brings vitamin K into our body to be synthesized in the liver. And vitamin K is necessary for synthesis or for production of 4 of the clotting factors, 7, 9, 10, and prothrombin, okay? Now, in that picture down there that shows the clotting cascade, we can see those circled. So there are 4 different parts of the clotting cascade that are affected with Coumadin derivatives, okay? And so our picture there says that once that initial platelets have aggregated in the area, they send out the chemical messenger to start that clotting cascade. And so instead of affecting the clotting cascade in one area, it's affecting multiple areas. And what that does when we take Coumadin is not that we won't clot at all, we'll bleed out, we'll die from that, but it slows down the time for blood to clot so that instead of it sitting in one place and making a clot, when our heart is pumping and blood is flowing, it pushes all that ahead and makes blood what we call thinner to be able to go through those vessels that may be damaged or to move easily through the veins to back up to the heart if our patient's stationary or things like that. Okay. The properties of warfarin, okay, the brand name is Coumadin, generic name warfarin. It can only be taken orally. So warfarin derivatives are only oral, okay? So what that means is they have to be metabolized in the liver before they become active. And so they last in the body about 1.5 to 2.5 days. The duration of action is about 2 to 5 days. So what that means for us is if, let's say, we'll talk about what the normal range or the normal numbers of range are that we want that patient to be in that show that the blood is thin enough or that the anticoagulant's effective. But to make changes in that, let's say that we do the blood levels and the blood is either too thick or too thin, it takes anywhere from 2 to 5 days for those changes to really happen. So it's a slower change in the body, okay? Increased anticoagulant effect when combined. Now look at all those medications. So any of those medications our patients taking can interfere with the actions of warfarin. That could be problematic. So what that means is warfarin is very sensitive to a lot of the things going on, primarily because all of those things that are metabolized in the liver affect the production and function of vitamin K. So when patients are taking any of those medications, in addition to warfarin, are Normal blood levels of anticoagulant can be very affected. The downside with Coumadin and warfarin is that patients have to have their blood checked at least monthly. Sometimes patients have to have their blood drawn and checked for levels of warfarin weekly or biweekly. It's very, very sensitive to not only medications we're taking, but food we're eating. We said that it interferes with vitamin K's ability to clot the blood. So, foods that increase the production of vitamin K, that bring more vitamin K into our body, green leafy vegetables, cranberries, apricots, there's all kinds of different things. Patients should eat lower levels of those things, lower amounts of those things in order to keep their levels of warfarin at an anticoagulation level that's necessary to prevent blood clotting. So patients that are taking antibiotics or aspirin or NSAIDs, they may be advised not to take those things. So it's very important that our patients understand that medications can interfere. So herbal medications in particular, particularly aspirin and NSAIDs. So those medications, which we've talked about before, are COX-2 inhibitors, COX-1 inhibitors. Aspirin has the property of an antiplatelet that interferes with the blood's ability to clot. A different clotting cascade and factor than warfarin, but it still interferes with that. So if patients are taking aspirin or NSAIDs, NSAID has a very short period of time where it interferes with platelets. But if they're taking aspirin or NSAIDs, then this patient could have could have increased anticoagulant effect. They could be at an increased risk of bleeding. So they would probably advise not to take aspirin or NSAIDs if they're taking Coumadin. And that can be problematic if they have an injury or chronic arthritis or get a headache or those kind of things. Now, acetaminophen is okay to take. It doesn't interfere. So they're probably going to be advised that it's okay to take acetaminophen, but not take aspirin or NSAID. So we could see that not only are we worried about foods we're eating, medications that we're taking, but also blood levels have to be done frequently. So that's kind of the thing that's problematic about warfarin. One of the reasons it's still prescribed quite a bit is because it's not expensive. It's very inexpensive compared to the other types of medications patients can take. So a lot of patients are still taking warfarin, okay? Comorbid conditions that can contribute to increased bleeding. So what types of patients may be at an increase of bleeding while they are taking warfarin? Patients with liver disease. So why? They're not producing vitamin K as well as they should be. Kidney disease, because warfarin or anything we're taking orally stays in the body longer because we're not able to excrete it as well if we don't have good functioning kidneys. So we could build up the dosages of medication in our body, such as Coumadin or warfarin. Tumors, think about tumors that we have on livers or kidneys or things like that. They can affect metabolism or excretion. Patients that have bone marrow failure has to do with the production of platelets. And so if we're not producing platelets, even though we're talking about medications that are anticoagulants, these conditions just interfere with our ability to clot. And so we have increased risk of bleeding. Bone marrow, we're not producing as many platelets. Chemotherapy can damage bone marrow. And then autoimmune diseases can damage bone marrow as well. So we don't produce as much platelets as efficiently as we could. Conditions for which Coumadin is prescribed. So why do we give Coumadin? Let's talk about some factors first. We said it's oral. So we're not going to give it if somebody is having an emergency where they have a blood clot, such as when they're having an active heart attack or when they're having, they have an active DVT, or when they are having problems where they have an active clot. We'll talk about it in a minute, but if we're going to do something where they are actively having a problem that is threatening a blood clot, we're going to give them something that's more quicker acting. Coumadin is going to be given after the initial blood clot is dealt with. This is for maintenance. Okay, prophylaxis means that we don't have a problem right now, but we're trying to prevent it. So if I have AFib, I don't have a blood clot right now, but I'm at an increased risk. So I could take Coumadin for that. Or treatment. So after I've had a blood clot and it's resolved, I have an increased risk. After I've had a heart attack and the blood vessels are opened back up and I have an increased risk. If I have heart valves with an increased risk, any of these things to prevent a blood clot from happening, not for the treatment of an active blood clot, okay? Because it's oral, it takes longer to act. What kind of tests do we do to monitor the action of warfarin, Coumadin? These are two lab tests. They're called PT and INR. And I'm going to kind of explain to you what the difference is. PT is the time for the fibrin formation via the extrinsic pathway. So kind of where it's shown there, the time for that blood clot to form from this level of factor 7. So it says it's a time. So PT is looking at the number of seconds it takes for the blood to clot, okay? So it's in seconds. And the test is performed by taking a sample of blood and they use a reagent. So it's something that is supposed to make the blood clot, and we see how many seconds it takes for the blood to clot. What we do is that PT is a ratio. So it's the patient's PT versus the normal PT. So the number of seconds, that's the difference between normal and blood clotting on warfarin. So if my blood clots in, I don't know, let's just say 3 seconds, and on Coumadin it takes 5 seconds, then the difference would be 2, right? So the difference between those two. So a normal PT is 1, because if normal blood clotting takes 3 seconds and I'm not taking medication and they check mine and it takes 3 seconds, that's normal. So there wouldn't be a difference in that. The problem is that there is a variation among the different types of reagents or the drops that they put on that to make the blood clot. So from one lab to another, the normal range may be different. So there's not an average or a normal number that I could say, okay, PT should be 3 or PT should be 2 or PT should be 4. It would be different from lab to lab to lab. So your doctor couldn't say, okay, you should want a score of this, because if you go to different labs, it may be different. So we think, why do we use it? Well, it is a very good descriptor. If we know in that lab, this is what normal clotting is, but we also want to look at something that is the same across all factors, and that's called INR. So if we're looking at warfarin ability to prevent clotting or to slow down clotting, let's say that, the blood tests we're going to be doing are called a PT-INR. We're going to look at PT, but we're also going to look at INR. And so next I'm going to kind of tell you what that is. So, well, this is a good slide that says the same patient, the same blood, but different laboratories, again, could give that different ratio depending on what type of test that they're using. They all use different types of reagents. So we could see at one lab, the normal is 1.4, at another one it's 2.6. So we would really have to look at the control from each of those. So we couldn't say universally, this is our goal for clotting with PT. So we use an INR. INR is International Normalized Ratio. Basically what that means is this is the number that no matter what lab you go to, what lab we're looking at, that we can say this is our goal. This is what your number should be. And so it is a great indicator of this is a second kind of number to look at. So it's a correction. It says it's a correction that corrects for the differences in the sensitivity of those reagents that are used in different labs. So each thromboplastin, each different type of reagent is assigned a number that's a sensitivity index. Anyway, what it boils down to is this INR value, if you're taking Coumadin or warfarin, is the same no matter what lab you go to. A normal INR for you and I who aren't taking an anticoagulant is 1, which means that the normal PT versus what it is when they draw my blood is 1, because I'm just functioning on normal clotting. But an INR of 2 means that their number is 2 times higher than normal. It takes twice as long to do the clotting. Okay, so we can look at it that way. And INR is more like, instead of seconds, it's more like how many times the factor it is to clot. So you and I are 1. 1 and 1 are the same, right? So normal blood clotting, my blood clotting are the same. But if somebody's taking Coumadin or warfarin, they take their clotting and it may be 2 for 2 times as long, or 3 for 3 times as long. So we can have a normal range that is universal. So let's look at that. So let's look at the same patient and the same blood. So we've got the same patient, what the normal PT is, what the ratio is. So INR and all of those, when we talk about kind of normalizing what the value of PT is, it's the same everywhere. Now, it's important to look at PT with the normal range, but also looking at INR can say, this is how this is the range we should be in. And lots of times doctors really look at INR to be able to say, okay, we know that the normal ratio should be 2.5 to 3.5. Is it in that range? Okay. So let's look at what the normal range of INR is. That if you and I were looking at the labs for a patient, we would say, oh, okay, it's in the normal range of clotting. So what's recommended for this warfarin or Coumadin that patients are taking orally? We want our patients who are on warfarin or Coumadin to have an INR of 2 to 3. The time it takes for clotting to happen when taking warfarin or Coumadin should be 2 times to 3 times the clotting it would be if they didn't have that. So again, prophylaxis or treatment. So we're trying to prevent either for the first time that a clot happens or repeated times that a clot would happen of a DVT in the legs. Treatment of pulmonary embolism. So again, we don't want a pulmonary embolism to happen again after it's been treated acutely. Prevention of systemic embolism. So a blood clot that's in the arteries or that's in an artery of the brain or the heart tissue, heart valves. Again, if we have mechanical, our tissue, our heart valves maybe aren't opening and closing the way they should. They have a murmur or they have some mitral valve leakage. So there's a risk for blood to sit there for a little while. Then we'll give them that. Acute MI, after the initial MI has been treated, so there's no longer a clot there, they may be given Coumadin or warfarin to take from then on out the rest of their life so that they have a decreased risk of having another heart attack. And then patients on AFib can take Coumadin to prevent a blood clot from happening due to the atrium not having that good contraction and the risk of blood sitting in the atrium and forming a clot. Okay. Recommended therapeutic range for other patients. So we said 2 to 3 is usually what we want patients to have. So if we're looking at a patient who's taking Coumadin or warfarin and we say, how is their therapeutic range of Coumadin or warfarin? Is it doing what it's supposed to? Some patients we want to have 2 to 3, but patients that are at an increased risk of clotting, even more so than these patients, are the next slide. So we want their blood to be even thinner, 2.5 to 3.5. So mechanical prosthetic valves. If we have mechanical heart valves, they're artificial. There is an increased risk of blood sticking and clotting to something that's artificial. So we want their blood a little bit thinner, even more so than the initial dose of other people we want on Coumadin. Acute MI to prevent recurrent MI. Now we saw that on the last slide. So this is to, it would depend on their risk. If I had an acute MI, it was treated and I had one blood vessel that was narrow, they opened it up, I may be taking Coumadin or warfarin and they'd want my INR 2 to 3. But what if I have multiple arteries that they had to repair? What if I have congestive heart failure in addition to thin coronary arteries? So if the patient is an even increased risk of having another clot, they may want them with an INR of 2.5 to 3.5. Again, their blood clots at a rate of 2.5 to 3.5 times longer than it would take you and I for our blood to clot. Okay, it makes it thinner, less likely to form clots, to move through those damaged vessels or tiny, tiny arteries. And then certain patients with blood clots, thrombosis, and the antiphospholipid antibody syndrome. So it's a kind of the patient makes antibodies. It's an autoimmune disorder where the patient produces these antibodies that interfere with um, the ability of Coumadin or warfarin to do its job. So they would give them higher doses of Coumadin or warfarin and want their blood to be even thinner to prevent the body from attacking that and causing clots. Okay, so these patients are at an increased risk than the patients in the last slide, and that would have to be determined by the physician. Okay. Okay, let's switch gears. Let's look at antiplatelets. Okay, so antiplatelets affect normal platelet function. We said platelets are always circulating in the blood system. So they are right there in the blood vessel if an injury happens, or if there is damage to the vessel wall. Now, damage to the vessel wall doesn't have to be that you and I were in an accident or we had damage from the outside in to the blood vessel. It could be damage due to very stiff and cracked blood vessels due to coronary artery disease, or not, I'm sorry, not coronary artery disease, but due to things that damage like atherosclerosis or plaque or cholesterol in the arteries. What it does is it makes them very hard and they can crack. And that's when clotting happens, an increased risk of clotting. So that's why things like diabetes that can damage blood vessels, hypertension, high cholesterol, all of those things increase our risk of clotting. So antiplatelets are affecting the ability of platelets to stick together. So that very first thing that happens. And so platelets adhere to each other to form kind of that beginning clot, and it tells fibrin, the other clotting cascade members, where to come to continue that. So this is kind of the first responder. Okay? Uses for antiplatelets: preventing heart disease. Okay, so instead of interfering with that huge clotting cascade we have, many times antiplatelet drugs may be given as something that is first used, or that is used to prevent things from happening instead of so invasively affecting that clotting cascade. Okay, it's easier to manipulate platelets than it is to interfere with that clotting cascade of anticoagulants, and it's also more easy to reverse that. So antiplatelets, prevention of heart disease. If you've ever heard of patients that were advised to take an aspirin a day, take a baby aspirin a day, it gives a decreased risk of those platelets from sticking together, but it does not affect the number of platelets that are in our system. So what does that mean? We're not affecting the production of anything. We're just affecting them sticking together. And this is important because this is I want to call it a less invasive way to affect what our body is doing. Anytime we interfere with what the body naturally does, kind of that clotting cascade, it's more difficult to correct if there's a problem, or we have increased risk of things that interfere with that. So antiplatelets are simply affecting the sticking together of them, not the number of them and not the production of them. So we can give antiplatelets during a heart attack. Okay, why is this important? Well, because patients can be given an anticoagulant to come at it from one side, but an antiplatelet to come at it from another angle. Okay, and antiplatelets don't stay in the body a long, long time. So we can do it initially and then it only survives the amount of time that platelets live, and platelets live 7 to 10 days. So antiplatelets will affect the platelets that are in our body right at this minute, but in 7 to 10 days, those platelets are gone. So the new platelets that are produced, they're not affected. Now, if we continue to take medication, they will be. So unstable angina, again, unstable angina is during a heart attack. If I'm having chest pain and I sit and I rest and chest pain does not get better, that means that there is an occlusion of a blood vessel. We don't want platelets to go to that area and increase the level of the clot following a heart attack. So maintenance therapy during or following angioplasty or stenting. So what this means is that if I want something that's going to act for only a certain period of time, so I've had an angioplasty, which is repair of the blood vessel, while I'm having that procedure and the days after that procedure, I want to prevent blood from sticking to that. And those platelets will stick to that because they're artificial. So in order to let that stent or that surgical area have tissue to grow over it and appear more normal to the body, we want to prevent those platelets from sticking to that, because when they do that, they're sending out chemical messengers to initiate the clotting cascade. So if we can just stop them from sticking to it, but we still have them circulating in the body if we need them, it's kind of less invasive than affecting that whole clotting cascade. Prevention of stroke or TIA. Again, they may be taking some kind of a low dose aspirin to affect how those platelets are going to stick in that area. AFib, low risk patients. Remember, this is not going to affect as intensely as an anticoagulant is. So if I have a low risk, I have AFib, but I still have a normal heart rate. So it's not AFib that's at a very fast rate. I have a lower risk of clotting, but I still have a little bit of risk due to that irregularity. They may start me on an antiplatelet. Now, if it got worse, then they may move to an anticoagulant. And then peripheral vascular disease, the blood vessels, the veins in our legs aren't constricting the way they should to help the heart pump blood back up. They may say, well, it's still moving, but we are worried that it's not working the way it should to help the heart pump fluid back up there. So we're going to prevent blood that is sitting there and moving slower from clotting up with these platelets. So let's go ahead and give them something that's an antiplatelet, a low dose aspirin. Okay. Antiplatelet drugs. So we said that aspirin and NSAIDs to an extent have an antiplatelet effect, but the difference, we've talked about this kind of with the COX-1 and COX-2 and how that they are affected. Aspirin is an irreversible effect. So what happens when we take aspirin, they affect the sticking together of platelets for the life of those platelets, 7 to 10 days. NSAIDs are irreversible, or excuse me, they're reversible, which means that they only last for a short period of time that the NSAIDs are active in our body, which is usually about 24 hours. So after that period of time, the platelets aren't affected anymore. Okay. Other types of antiplatelets are clopidogrel, taclopidine, persantine, and these are given many times. Let's see, Plavix is an oral medication and it's given at home. It is a little bit, it's longer acting. So we wouldn't want patients to take aspirin, a high dose of aspirin all the time, because it affects other things. So we know aspirin is an antipyretic. It affects other functioning of our body, but Plavix is an antiplatelet that only affects platelets. And so patients may take Plavix for longer periods of time. Ticlid is the same way. Ticlid is a medication that many times, if patients are going to be started on this, they'll come into the hospital and we'll give it to them and continue to watch their level of blood clotting, as well as their heart rate, those type of things. So these other medications can be taken for a longer period of time, and their actual purpose is to work as an antiplatelet, so to prevent platelets from sticking together, whereas aspirin and NSAIDs have that as kind of one of their effects, but they also do other things. And so they have an effect on, like it says here, the mucosa of the stomach, blood flow to the kidneys. It affects other parts of the body. So we wouldn't want to take them on a regular basis, full strength, just for the antiplatelet effect. So how do we measure the antiplatelet effect? There are a couple of different tests. These are two that I haven't really seen recently. I left this in here just because they may be things that the laboratory uses. It's called an IV blood, a bleeding time, or platelet function analyzer. So basically what they do is they look at platelets. They get a sample, a blood sample, and since platelets are always circulating in the blood, they get a sampling of platelets, and they put something on there like a reactor to see how fast they'll clot and form a plug. And so they get a ratio or a number from that. Okay. Usually patients are taking antiplatelet drugs. They are for prophylaxis. And we don't really monitor the ratio or the numbers on that the way we would an anticoagulant medication. Again, they affect platelets for the life of the platelet. So unless our patient was having an life-threatening or uncontrolled bleeding episode, they probably wouldn't be looking at these to see what was going on. Okay, and that would be from like a car accident or a major surgery or something like that. Now, they do have an effect of course, preventing platelets from clotting together. So if patients are having surgery, whether we're talking about dental work or we're talking about outpatient surgery, inpatient surgery, depending on the patient's risk of clotting, the risk of clotting versus the risk of bleeding out, the doctor may have them to stop their antiplatelet or anticoagulant 24 to 48 hours before surgery. Now, if the patient is taking a dose, either that is not a very high dose or their risk of having a blood clot is very, very severe, they may not stop them, or they may change the dosage right before surgery. Okay. So antiplatelets, we can look at this again and see that there are different ways that these medications affect platelets sticking together. We said aspirin and NSAIDs as well, but particularly aspirin because it lasts the life of the platelet, interferes through these COX inhibitors. Other medications interfere through other receptors, and then the third medication works through other inhibiting other receptors. So again, just what I want you to see from this is there are different ways that medications interfere with platelets sticking together. So that's why there are different types of medications. And like we said, some of these medications, their only job is to prevent platelets from sticking together, and they may prevent them from sticking together for a longer period of time, whereas something like aspirin is going to work to thin blood or to prevent platelets from sticking together for the life of the platelet. But usually we just use a low dose of that, and it affects other parts of the body like the GI system, increased risk of having stomach ulcers. So we wouldn't use that for the intense purposes, a full dose of aspirin continuously, because they have other side effects. Okay, so lab tests to monitor anticoagulation effect. Here are the numbers we're looking at. And so let's back up, and we've left antiplatelets and we're looking at a number of factors. We said that there are 3 different types of anticoagulants. There are the Coumadin, there's the Coumadin warfarin type medications, there is the heparin and heparin-based medications, and then there's the 10A inhibitors. Again, they're all working on different parts of the clotting cascade. So we would use different types of labs to see how they are affecting that part of the clotting cascade. PTT is a lab we would look at for heparin therapy. And this is how I remember PTT. See the two T's at the end of the PTT? If you put those two T's together, especially lowercase t's, they form an H. And so that's how I remember PTT is for heparin. And PTT is the number of seconds it takes for the blood to clot. So for heparin therapy, the norm is 33 to 45. Now you'll have that norm on your labs that you'll get back. It has the normal range, but that's for heparin therapy, and it's maintained at about 1.5 to 2 times the normal value. So 33 to 45 seconds is about 1.5 to 2 times longer than it would take for our blood, you and I, for our blood to clot, because we're not taking an anticoagulant. The next one is PT. PT is prothrombin factor, and that is for warfarin or Coumadin, okay? So PT is maintained at 1.5 to 3 times the control value. And if you see that 1.5 to 3 versus 1.5 to 2 for PTT, they're the same kind of a ratio, right? They're the same kind of a ratio that's 1.5 or 1.5 to 2 times or 1.5 to 3 times longer than it takes to clot, but they're just different parts of the clotting cascade. So we have to know what type of lab, and the laboratory, of course, has to know what type of lab to run to look at that part of the clotting cascade. So normally, if the patients are taking this medication, we want the time for the blood to clot to be a little bit longer. Okay, we don't want it not to clot at all, we'll bleed to death, but we want it a little bit longer. So looking at the number can help us. And we said that PT is one of those labs that's different from lab to lab to lab. So with PT, we put something called an INR. And INR is going to not be the seconds, but it's actually going to be the time. So PT is the number of seconds, 12 to 14. But if we're looking at INR, it's a ratio, and it's going to actually be the 1.5 to 3 or something like that. So maybe their INR is 1.5, maybe it's 2, maybe it's 2.5, maybe it's 3. So that's going to be the norm for INR. And blood time, normal is less than 9. I don't really see that used a lot, but that's something that may be used. Anticoagulants and prophylactic antibiotics. So we said that one of the things with anticoagulants is that, particularly if we're talking about Coumadin and warfarin, right, that a lot of things interfere with it. So even if we're talking about heparin, which I'm going to talk about heparin in a minute, and 10A inhibitors, but any of those anticoagulants can be affected by antibiotics because they are metabolized in the liver and they can interfere with clotting factors that are formed in the liver. That's where our clotting factors are made. So it says a single dose of an antibiotic. So before surgery, sometimes for prophylaxis, they'll give 1 dose of an antibiotic. That's probably not going to affect the clotting time, but if the patient's getting multiple doses, it can affect the clotting time. So that doesn't mean they won't give antibiotics. We want to treat an infection, but what that means is they will need to have their clotting time measured more closely while they're taking an antibiotic and an anticoagulant, okay? Just to make sure that the clotting time is still within that range. We don't want it less than that because that means the blood's thicker, it clots faster, and that wouldn't be doing the job of the anticoagulant. And we wouldn't want it higher than that because it means that it takes longer for the blood to clot than we want, and there's an increased risk of bleeding with that, okay? Within the normal range is decreasing our risk of clotting and excess bleeding. What about analgesics? Okay, we said aspirin, NSAIDs, they also affect the ability of platelets to stick together. So we're getting kind of a double whammy there of the anticoagulant cascade and the platelets. We've got to be really careful with that. So we do recommend that patients avoid things like ibuprofen, aspirin, NSAIDs while taking anticoagulants, and paracetamol or acetaminophen, Tylenol, is really the safest option for those patients. Okay, so I don't have another slide, but let me step back. We said 3 different anticoagulant main categories: Coumadin or warfarin. We talked about that, okay? We talked about the upside and the downside, okay? Upside is that it's oral, they can take it at home, that it works very well. and patients can manage it on their own. Downside, you have to get blood work drawn at least monthly, okay, to monitor that it's staying within that norm. And why? Because it's affected by a lot of things. It's affected by medications. It's affected by foods that have vitamin K in it. Why? Because the antidote for Coumadin or warfarin, or excuse me, the reversal agent, let's say, the opposite of that, the antagonist of it, of Coumadin or warfarin, is vitamin K. And so increasing levels of vitamin K can prevent the anticoagulant effect of Coumadin or warfarin. So they have to watch the foods that they eat, the medications that they take, and they have to get their blood work checked at least monthly. Okay, well, that's a lot of work with Coumadin or warfarin. But we also said that it's inexpensive and that it works well. And so a lot of patients are still on Coumadin or warfarin. Insurance covers Coumadin or warfarin, okay, because it's a lower cost. Let's move on to heparin. Heparin, or you may have heard of Lovenox, which is a low molecular weight heparin. That is Lovenox. When we say it's low molecular weight heparin, heparin affects a number of different clotting factors. The low molecular weight heparin, which is Lovenox, only affects one of those. So it is a less potent type of heparin, okay? Downside, heparin can only be given in an IV, okay? It can, or in a sub-Q. So it has to be given IV or sub-Q. It's not an oral medication. It acts very quickly. So we would use heparin if a patient was actively having a heart attack, okay? If a patient was actively having an ischemic stroke, so they would do something, another medication, a prothrombin medication, to potentially dissolve or to break up the clot, but to actively, very quickly, keep that blood thin, they could use heparin. And it wouldn't be just an injection of heparin, it would be a heparin drip. So they would have a bag of heparin that would be running continuously. It acts very quickly and it acts very well. So it would be given in the hospital, okay? You wouldn't be giving heparin at home in an IV. So it's used for very acute episodes of bleeding. It also has to be monitored very carefully. If it's acting very quickly and it's going into the bloodstream, we have to make sure that the dose is in that correct range. So they have to have blood work done when they're getting a heparin drip about every 6 hours. If the blood is therapeutic and it's in range, then they can extend that time. But anyway, in the hospital, you are making very, very careful that you're hanging the correct dose of heparin. You're putting the correct time for it to run, the infusion rate on the pump. You have to have 2 nurses to verify that it's the correct rate on the pump. That's how serious it can be if you make an error. And you have to make sure that the next lab work is ordered in the lab at the correct time. So it has to be monitored very carefully, okay? And again, the lab work to monitor heparin is PTT, okay? So the 2 T's make the H. PTT is the lab that will be monitored in the hospital to look at the time it takes for blood to clot when a patient's taking heparin. The reversal agent for heparin is called protamine sulfate. And you will always have that in your Pyxis or Omnicell or whatever your medication machine is on your unit, okay? Working on a different part of the cascade is a new type of anticoagulant called 10A inhibitors. And I'm going to roll all the way back up here to the beginning when we looked at the clotting cascade. And here we can see, if it shows it on here. So it does not show factor 10 on here, but factor 10 is a different part of the clotting cascade that can be affected. So these new types of anticoagulants, we'll talk about kind of the ups and downs of those. The 10A inhibitors are fairly new. They're the ones you hear about advertised on TV all the time, where people are talking about that they've had a DVT or a stroke and that they take this medication, and they talk about how wonderful it is. So we're going to compare it to another oral medication. So 10A inhibitors are oral. That means they wouldn't be given for an acute episode that was happening right now. That would be heparin. But patients may at home be taking 10A inhibitors. These are things like apixaban. The brand names would be things like Xarelto, Eliquis, Pradaxa. They're very expensive. So insurance many times doesn't cover the full cost of these. Patients like these because they don't have to have labs done all the time like they do with Coumadin. Because 10A is not affected by the foods that we eat or affected as a whole from other medications. So patients taking 10A inhibitors are much more free to eat a diet with all the foods they want. They don't have to restrict the amount of salads or greens or certain types of vegetables they eat. They don't have to have blood work taken all the time. And it's more stable in, due to those factors, in keeping coagulation at a normal level. So the number that we would look at to tell if patients were taking 10A inhibitors and they were working effectively, the lab is called a 10A. It's called a 10A factor, and they can draw that to tell if that clotting factor time is at a level that they want it to. One of the downsides that we've heard about is that there's no reversal agent for 10A inhibitors. That's not quite true anymore. There is a new reversal agent for 10A inhibitors. It's called Andexa, Andexxa. And that's a kind of a new factor. And it's only given as a reversal agent for someone who is having life-threatening or uncontrolled bleeding. So let's say that I've been in a car accident, or I've had major surgery, or something like a surgery that was emergent. Then the patient could be given this Andexa to bring their clotting time down so that the risk of bleeding out while on that medication isn't so severe. So there is reversal agents if there is an emergency, but we don't worry about a reversal agent like we do for Coumadin for 10A if it's not life-threatening, because it stays in the therapeutic range much more closely. So the risk of it getting out of range due to other medications or foods or things like that don't occur as much as these 10A inhibitors. So they are kind of advanced, and they are they're safer, a decreased risk of clotting, causing a blood clot or bleeding out. And patients like them. They're easier to use without all the restrictions and blood work, but they are more expensive. And so that's a downside of that. Again, this is an overview that I wanted you to have, really explaining the differences. If you have any questions, any concerns, please reach out to me. Have a fantastic day.